us today. Dr. Rida Jamil is covering the adult side, and then we have Dr. Shahryar Khan, who's a pediatric consultant here, and he would be talking a bit about the PED side of the things. So I would hand it over to Dr. Rida. Just to let you guys know, I've emailed Dr. Hadi this morning with an attendance sheet. So I would be very grateful if all of you can leave your email addresses and send that across to myself so that I can send you a feedback form as well as the certificates of attendance. And also if I have the email IDs, it would be easier for us to send you a schedule about the upcoming tutorials. And if you have any feedback or any suggestions or anything in particular you would like us to add on, we would very much look forward to hear back from you. Thank you. I'll pass it on to Dr. Rida.
We have arranged a pro forma and which there will be details of the names and all the email addresses of the participants. And after the session, I will share with you.
Thank you.
Assalamu alaikum. Can you all hear me?
Yes.
Hello.
Yes, we can hear you.
Oh, great. Cool. Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I'm Dr. Rida Jamil, and I basically graduated from Allama Iqbal Medical College, came to UK 4 years ago, and I'm currently working as a co-medical trainee in West Midlands. So today I'm going to share something which I found very fascinating when I first came to UK. And the most fascinating thing about this scoring system was that it was so basic, yet so pivotal and so useful in preventing, well, actually detecting patients who were about to deteriorate and actually to intervene just in time to prevent them from actually dying. So rather than coming one fine day to see your patient dead, you can actually identify when he's about to crash, intervene appropriately, take the appropriate steps, and then actually prevent a calamity from happening. So this system really, really did impress me, because I had worked in Jinnah Hospital for my house job and had worked in private setup in Pakistan as well, in Lahore. And although these were things that we were doing, but we were probably not doing it the way they were being done here and how they were used here. So it's something very useful, very basic. And in the coming slides, I will tell you what we mean by news and how we can actually practically use it. So news basically is known as the National Early Warning Score. And this was basically introduced in the UK to identify patients who were going to deteriorate, and then, to actually intervene and to take appropriate steps to actually prevent that from happening. And this would obviously improve the overall clinical outcomes, patient outcomes, and mortality. Now, the question is, why use it? The basic advantage of using news is that it actually categorizes your patients. It actually makes you aware which patients require frequent observation, require more medical attention, or which patients are doing fine, are responding to treatment, are relatively stable. And the ones that are not stable, then you can actually think and plan in advance whether they need to be transferred to a specialized unit such as an ICU or a CCU. Now, talking about the news score, what exactly does it consist of? So it basically uses the 6 simple physiological parameters, which I'm sure you are doing all the time for all of your patients. That is your rest rate, your oxygen saturation, your systolic blood pressure, your pulse rate, their level of consciousness, whether they are responding to you or any acute confusion that they develop, and then their temperature. Now, see how basic these things are. And I'm 100% sure, because as a house jobby in Lahore, I used to record all of these, but probably I was not using that information to help me, because this news score, more than the patients, it's actually helping us to decide which patients are critical and would need more of our attention. So you don't need any fancy tool to record all of these. So the reason I'm emphasizing on all of this again and again is just to tell you how simple this whole thing is and how easily achievable and doable this is. Now, these are the parameters. Now, how do we score? So for rest rate, again, anything less than 8 will score a +3. Anything less than 25 will score a +3. Then your 12 to 20 is your normal heart, your rest rate, so it will score a 0. 9 to 11 is +1. 21 to 24 is +2. For oxygen saturations, again, anything less than 91% will give you a score of +3, and anything above 96% is normal, so it gives you a score of 0. And the rest, again, you've got a +2 for 92 to 93 and a +1 for 94 to 95. Then we have any oxygen requirement. Now, this is a simple yes or no. It does not quantify how much oxygen they're requiring. For example, even somebody requiring 2 liters of oxygen and somebody requiring 15 liters of oxygen would both equally score +2. And if they're not requiring oxygen, that would be a no again. Again, similarly for temperature, less than 35 is +3, greater than 39 is +2. And then you have all these categories where your 36.1 to 38 is normal, and 35.1 to 36 is +1, 38.1 to 39 is +1. Now we move on to blood pressure. Anything less than 90 or greater than 220 will give you a score of +3. 91 to 100 is +2. 101 to 110 is +1. And then your 111 to 219 is considered normal. So will give you a score of 0. Similarly, heart rate, you've got bradycardia less than 40 +3, 131 +3, and then you've got relative bradycardia 41 to 50 will give you a score of +1. 51 to 90 will give you a score of 0. And as you can see, 91 to 110 is +1, and then 111 to 130 is +2. And then, as I mentioned about alertness, anyone who is alert, that is responding to you, is awake, will give you a score of 0. But anyone who is either unresponsive or is only responding to your voice or pain will give you a score of 3. Okay, so now I have gone through this very complicated mathematical scoring, and you would be wondering that by the time you end up scoring your patient, he would be long dead because it's so confusing. I agree with that. So that's why, to make things simpler, what we have is known as a news chart. It's, I'm sorry, not very clear here, but just to give you the gist of it. So this is the chart that we use to record the normal observations of a patient. So whatever observations you take, you have to record on this chart. And it's a very easy to use chart, very self-explanatory. Any value that falls in the category of orange, dark orange, will automatically give you a score of +3. The yellowish lighter orange will give you a score of +2, and green is +1. And anything white is normal, is 0. So you actually don't even have to remember the values. You just record your values, whatever the heart rate of a patient is, you just record that. Whatever color it falls into, you would automatically know that it's a +3 or a +2 or a +1. And honestly, you don't even have to be a doctor to do that. Like here in the UK, it's the nursing staff that does that. And so if you look in each column, so basically it's oxygen saturations, then it's blood pressure, heart rate, temperature, and in the end, you write down the total news. And depending on what the news score is, the nurses will then alert you. Now, when we talk about news score or high news score, what you need to know is that anybody who scores an overall score of 5 or a score of 3 in a single category is your high risk patient or is your unwell patient. So you have to respond to that patient. So just by your normal physiological parameters, just by your normal observations, you can actually decide whether your patient is unwell or not, and whether he needs your urgent medical attention or not. That's why I consider it extremely useful. For example, you come to the hospital, you come to your ward, there are like 50 patients that you have to see. You don't know how to prioritize them. All you need to do is ask the news score. If they're scoring a 0 or a 1, at least you can reassure yourself that fine, we can come to these patients later, and then you can actually use all your energy to sort out the ones that are using high initially. Now, as far as fine, we've scored them. Now your patient is scoring a news of 5 or 6 or 7, and if obviously is acutely unwell, what to do about that? Now, we will be covering all of this because it's a very long and a very important topic, and we will be discussing it in our subsequent sessions. Today, I just wanted to introduce you to that system of new scoring. However, I will just like literally give you a rough idea as to what to do. Now, if the nurse calls you and says that your patient is scoring a NEWS of 6 or 5 and he needs to be seen immediately, what you need to do is you need to assess the patient using an ABC approach. Now, what this ABC approach is, that it checks for airway, breathing, and circulation. Again, this will be explained in extreme detail when you in our further session. So I don't want to spoil the fun. I will go into details of that. But anyhow, I will just give you a very brief idea. So whenever your patient is scoring high, just go assess the patient, make sure, of course, he's alive and he's responding. You secure an IV line. You are going to take some blood samples, which will include your full blood count, your CRP, your electrolytes, your blood cultures. Now, just a few tips. If somebody is spiking a temperature in hospital, the first diagnosis that should come in your mind is sepsis. So think about sepsis. And of course, if they have a clear source, for example, if the nurse is telling you, oh, doctor, they've been coughing, or the urine is very strong smelling, then you at least know that, okay, fine, the infection might be coming from the chest or the urine. Or if you see a new rash, you could think cellulitis, and then start the patient on appropriate antibiotics. In the meantime, if you cannot find a source, then of course you can start with a broad spectrum antibiotic. Then you can also give him, you should also give him IV fluid, request chest X-ray, do an ECG, send urine culture and sensitivity, monitor input output. Now again, this is very important. One of the markers of acute deterioration is patient not producing enough urine. So make sure, and if the patient has not passed urine, do catheterize the patient so that you can actually monitor how much urinary output he's producing. And now, if the patient is already on antibiotics, but is still spiking temperature, let's say your patient, you're already treating him for a chest infection, he is on co-amoxiclav, he was perfectly fine, and now he's spiking a temperature again, and his NEWS has gone to 6 because his blood pressure has dropped, he's become tachycardic, he's become his tachypneic. Now what you do, try switching the antibiotic, move to a stronger antibiotic. Again, any patient who now has a new oxygen demand and is tachycardic, tachypneic, has no temperature, think about other differentials. Of course, he's been in hospital for long, he's been immobilized, could it be PE? So just keep an open mind. Similarly, a patient was just perfectly fine, and now his blood pressure shoots up. He is requiring oxygen, and he's got bilateral crackles. Think about acute cardiogenic pulmonary edema. Now, this was a very basic slide, and the reason I'm not stressing on this is because we are going to cover all of this in extreme detail because it's a very important topic, how to approach an acutely deteriorating patient. But I just wanted to include this in today's presentation just to tell you that it's not about actually scoring somebody on NEWS and just do that and be fine. No, but it's actually what comes after. So, I mean, you've scored him, but what to do next? So that's why I basically included this slide. Now, exceptions and adjustments. Obviously, no system is very transparent. No system is absolutely dot to the point. You have to make some adjustments. For example, a patient of COPD. For COPD, your ideal saturations are 88 to 92%. So he will then not fall into that category. If you remember, when I was scoring this system, I told you that for oxygen saturations, less than 91% is a score of 3. So does that mean that all COPD patients would always be scoring 3 for that? No. In that case, there's actually a section on the NEWS chart, which is not, this slide is not very helpful because it's not showing you, in which you can actually deviate to what is known as scale 2. And you can make those adjustments that for a COPD patients, their saturations do not consider scoring them a 3. You can make those adjustments. Then, of course, let's say a patient comes in, he's got bilateral PEs, massive PEs, He's hypoxic, tachycardic. You've already started him on a treatment dose of heparin. He's otherwise fine. Now, of course, naturally, he would keep on scoring, let's say 4 or 5 because of his saturations and his heart rate, because he's got a massive PE and it will take a while before that improves. So in that case, even if the patient is scoring 5 and has maintained that score for a couple of days, there's not much you can actually do about that because you've given him the right treatment. Now you just have to wait and respond to that, wait and watch. And that will only be a problem if, let's say, his score increases or jumps from a baseline of 5 to 10, which means he suddenly develops hypotension. He suddenly becomes extremely hypoxic and his oxygen demand increases. It's only then you would be worried. But for these patients, you would be able to kind of accept a high new score, like 4 or 5. Like a lot of times when you're on call and the nurse calls you and says, oh, doctor, this patient has a news of 6, can you come review? The first thing I do is I log on to my computer and see what his previous new scores were. If they were already a 4 or a 5, a new score of 6 is not going to affect me. I wouldn't be too fast to go see the patient and fix him. I would be like, okay, fine. He's always been unwell. However, if the doctor's, the nurse calls and says, oh, doctor, this patient has a news of 10 and his baseline news was 5, that is where I would be jumping and I would be crying and I would be actually running all over the place. So, yeah, so PE. Similarly, any patient of heart failure, let's say, is on an furosemide infusion. Now, again, he's got end-stage liver heart disease, severe left ventricular failure. Now, he's bound to be hypotensive. So, I mean, if he's scoring a +3 for his low blood pressure, I wouldn't again be too much worried as long as he's not symptomatic with that, because I know that he's coming with advanced heart failure. I'm already treating him. His ejection fraction is already too low. So he's bound to have a low blood pressure. So that is acceptable. And then again, if somebody is already septic, you've already given him the best possible antibiotics. He's on the right treatment. He's still requiring, let's say, for a massive pneumonia, he's still requiring oxygen, or he's still slightly tachypneic, but you've done all the measures and you've given him the right treatment, then again, you can kind of accept his high score. So the bottom line is that it's not just about numbers. You don't treat numbers, you treat the patient. So always look for signs of deterioration in the patient rather than just go by numbers. So that's another thing that you need to keep in mind. So just to summarize, what we discussed today is the new score. It's the National Early Warning Score. As implied by its name, it warns you that a certain patient is about to deteriorate. You don't have to use any fancy technology to do that. Literally, I mean, you can actually hire, like literally, you don't even have to be a medical professional to do that. Anybody can check the pulse rate, temperature, blood pressure, saturations, rest rate, and see if the patient is alert. And record the numbers, so that when you are doing your ward cover or when you come and you don't have enough time to prioritize your patient, just in a glance, you can decide which patient is unwell and which is not well. And then you can, channel your resources to the more unwell patient. Similarly, you've started someone on treatment. A new score is a very good guide to tell you if they're responding. You will actually see that the new score is coming down from 6 and 7 to 2 and 1. So, like I said, I found this extremely fascinating. And I was like, I wish we had such a system placed in Pakistan where, we wouldn't have to, just by the news, because when a patient is deteriorating, let's have a look. Let's say if somebody is deteriorating and is developing an infection, he's not going to be crushed then and there. He will first show you some signs of infection, right? For example, his temperature will slowly creep up. His heart rate would slowly creep up. His oxygen demand would slowly increase. So that is where you have to intervene. And that is where you have to fix that patient rather than waiting for him to develop that very severe disease and take it to a point of irreversibility where you actually cannot do anything. So that's the whole concept, to basically detect early warning signs of a patient that they are about to deteriorate and to actually intervene and do your best. And then obviously, I guess if you include this in your practice, I'm quite sure this is going to be a valuable thing added to your medical practice. And of course, you don't have to follow the exact same system. If you guys have modifications of your own, feel free to do that. But that's the whole idea that I just wanted to actually give to you guys today, so that at least you would think about it and, you know, probably take some action or try to incorporate it in your daily practice. So thank you very much. I don't like torturing people with long presentations, so I try to keep it very small and to the point. So if you have any questions, feel free to email us, because I'm not sure if the audio link is working. So that's all about it. Thank you.
Thank you, Rida. Very nice and precise presentation. I think Shariar will be ready for the next talk, which is basically more the pediatric aspect of it, but can be, I mean, the basic concept is the same and can be applied to the adult as well. So I'll hand over to Shariar next. Over to you, Shariar, please.
Assalamualaikum everyone. So I just wanted to know first, because the video of our Saidu colleagues is not showing up. So is the audio working? Khwaja, do you know?
Yes, audio is working properly, but when we turn on the video, the link is not supporting it.
That's fine. So your audio is working. So do you have any pediatric doctors over there in your audience? Because I don't want to bore you guys a lot, the adult doctors, with my pediatric talk.
Yes, we have.
You have a few.
We do have colleagues over here.
Okay, great. I heard from someone that Saidu Medical College has like 50 or 60 pediatric TMOs. Is that correct?
Yes, it is.
Oh my God. So 50, 60 in one hospital. That is a lot of pediatricians that you guys are training. So, okay. So let me just go to my
video or
yeah, it's absolutely fine. So the video is fine, but it may. So I'm just going to share my screen. Okay. So sorry. Oh, okay. Sorry about that. Okay. Let's start. So I'm going to talk about the approach to a deteriorating child. So similarly to what Rida said, PEWS is also employed in the pediatric practice. My presentation is going to be, I'm going to touch on a few other aspects as well, not just PEWS, just so that you guys learn about a few other concepts that we practice over here, and hopefully employ it in your setting as well. So my name is, so my name is Shariar Khan. I'm one of the pediatric consultants practicing over here in the UK. But this is where I come from. So I come from Peshawar. I'm originally from Sawabi, but this is where I studied. So I have very fond memories of KMC. This is where I used to go when I was in KMC. I practiced for around 3 years over here in Hayatabad Medical Complex. So I worked in pediatrics. So don't just think that when we come over here to UK, we don't know what the situation is. We very well know what the situation is back in Peshawar. And of course, it will be similar in Saidu as well. And I found out that there's lots of pediatric trainees and there's very good pediatric training program over there in Saidu, probably better than Peshawar. And this is where I worked. So I worked in quite a lot of places over here in UK. So what it does, that when you are in a training program over here in UK, when I was outside of training, I worked in a few hospitals, then I went to lots of other hospitals. I just hated it. When they used to rotate us, every 6 months in different hospitals, I was like, am I an army officer or, like what is happening, uprooting you from one city to the other and then to the other. You always have to relocate. But you know, in hindsight, I think that was a great opportunity for me to learn from different teams. So I think what happens in Pakistan and say, for example, the US as well, you are in one hospital for 3-4 years. You don't move around, and you kind of get comfortable in your hospital environment, or in your ward environment. You start to feel like a king, and you think that you can do whatever you want, and you slowly and gradually, as you progress, you start to relax a little bit. But what they do over here in the UK is, when they move you into different hospitals, they don't let you settle. You learn from different teams, you learn from different nursing teams, you learn from different consultants, and then you pick and choose. You pick and choose what you have liked, and if you have disliked an environment, then you forget about it. You don't carry it forward to another hospital. But I've worked in quite prestigious hospitals. I was just lucky that I worked in those hospitals. But then now I found, so I'm working currently in Maidstone and Tunbridge Wells. So we are in the southeastern part of UK. It's called Kent, and it's based on 2 sites. This is where I work as a pediatric gastroenterologist at the moment. But my core training is in pediatrics. And I still do some pediatrics, but I mostly do gastroenterology. So over here in the UK, what they do is they will, you know, shove a lot of guidelines and protocols and everything into you. So I don't know about news, but PEWS is not a nationally recognized scoring system. So it is just a tool which you use. So Royal College is very actively working with NHS England to officially recognize PEWS as a tool. So it is not a medical legal document. It is just a tool which helps clinicians. But Royal College, so what they do is they're very clever. So they will make documents, then they will ratify it, put it on their website, and suddenly it becomes an official document. And, you know, so you have to keep an eye on these documents over here, especially when you're a consultant. You have to know what is a legal document, what is a non-legal document. And they will say, okay, they've produced a document which is called Safe System Framework for Children at Risk of Deterioration. And it will be like an 18-20 page document. And out of that, they will say, recognizing deterioration and responding to deterioration. So these 2 aspects, and they will say, PEWS is a mandatory tool which everyone should use in the country to recognize a deteriorating child. And suddenly, when you go to the court, if you have not acted on something, then they will say, okay, this was a document that we made, you should have read it. So we always have to be on our toes, and we always have to know what is, whether something is there or officially or not. So now my objectives, so that's just basically giving you a background about myself and about, you know, how you should be aware of such documents and such tools which are available. So you cannot really say that, you know, I didn't know about it. So the objectives of my presentation will be that I'll, you know, or what is the objectives of basically PEWS, which is Pediatric Early Warning Score. So I'll be talking about how to identify early deterioration, similarly to what Rida said, you know, in the adult practice, same goes for pediatrics. Timely and appropriate response to a deteriorating child. So you can't just identify someone and just go off to tea or coffee. You have to then respond to that. And a structured handover. So a structured handover is, you know, it's mandated by the Royal College as well as GMC. So GMC will tell you that a handover is a mandatory part of your day-to-day practice. So what is a pediatric early warning score? So it's basically same as adults. It aims to assist in identifying a deteriorating child. It does not replace your clinical judgment. So I like PEWS, but I sometimes dislike it as well, because the nurses will, you know, always keep on calling you and saying, oh, this child is PEWSing 2, this child is PEWSing 3, just because the algorithm tells them that you have to call the doctor. But you are still a doctor. You still have to decide. Even in the UK, you can decide and say, no, I'm happy about the child. Just like Rida said, you can tell them that, yeah, I know about the two. I'll just sit on it for a while. You know, keep on doing observations. So it does not replace clinical judgment. So there are different versions of PEWS. So as I said, it is not a nationally recognized monitoring tool. Every hospital has a different PEWS chart. It's not like news. So news is mandated by NHS England. It is recognized by NICE as well. PEWS is not. So key is to use one standard for your organization. And I think our presentation, this current presentation, which I'm doing, it is for doctors, but it's mostly for nurses. This presentation that I'm doing, because PEWS should be understood by nurses first. They have to do the PEWS to alert you. So I think in the future, if you take something forward from this presentation, is that I can send you our guideline, I can send you the charts, the PEWS charts that we use, and you know, just print them out. It's just one page, and you can use it for your children, but your nurses need to understand how they should be doing PEWS. But of course, you also need to understand the importance of PEWS. So what is an ideal PEWS tool? It should be validated, it should be easy to use, practical, and it's a generic one document, and it should meet the hospital needs. So I cannot bring a UK PEWS and put it in, you know, Saidu hospital, because let's say, for example, you guys may not have saturations in that department. I'm just giving you a hypothetical example. So then that chart will not be, you know, acceptable to your, or it will not be basically useful for your practice. So there's different types of PEWS charts. Again, as news, it is not a single document. So there's different type of, there's a scoring system, there's a score type of chart, which similar to the adults one. So you score in different domains, and then you act on certain scores. So a score of 5 will tell you, oh, well, it will tell the nurse, this is what you have to do. A score of 8 will tell us. But what we use in pediatrics is a threshold type of PEWS. So that is much more easier to administer. And so each have a different, you know, so scoring one, it will take all observations into consideration, while a threshold one will just give you, you know, you will just put one over there. And so I'll show you, it will become much more clearer when I go to the charts. Okay, so my charts are loading. So these are different type of, you know, so this is the one, so the middle one looks like the adult one. This is not what we use, but we use something similar to this one. So say, for example, I'm going to go to my chart now. I think you should be able to see it clearly now. So in pediatrics, some of my pediatric colleagues over there sitting in the audience, they will understand that every age group has a different normal, not like adults. So in adults, you know, you will have a heart rate, let's say, for example, more than what? More than 100 or more than 110, you will say this is abnormal. But in pediatrics, in a 9-month-old, you can see that a heart rate of even 160 is not scoring. That's normal. So in a 9-month-old. So, you know, there are different age groups. They are taken from various different, you know, guidelines. Can you see my cursor? So it will just say, like, so let's say, for example, so the nurse will be scoring on this, not the doctors. So the nurse will say, okay, the respiratory rate of a 9-month-old is, let's say, 60. He is in respiratory distress. He has a heart rate of, let's say, 140. Conscious level, it's normal. Temperature is 35. Cap-refill is less than 2. Hence, he scores this much. Yeah. So if it falls in the red zone, that will score 1. Yeah. So in each domain, you can either be 0 or you can be 1. And whatever the score comes out, you put it over there. But then what do you do about it once you put the score over there? So what does the nurse do about it? So these are just different age groups. So this is sort of a guidance that we have given the nurses. Look at this section. So, you know, this green, yellow, and red section. So let's say, for example, if a child is scoring 0 or 1, the nurse will just continue monitoring. If it scores 2, she will let the nurse in charge. So she will let the nurse in charge know on the ward, and then she must review, just to make sure that all the observations, whatever is done, they're all, you know, they all have been done correctly. Number 3, so if they score 3 or 4, this is what they do. So they will just, you know, so that's why anybody on the acute ward, the nurses will be on the phone all the time to you. So nurse in charge and senior medical review within 5-15 minutes if it's scoring 4. But if it's scoring 5 or 6, they will go to senior medical assessment. So they may call the consultant. So they have the, you know, they have the right, and they have been given the freedom over here to call anyone. So in the middle of the night, the nurse will be calling me, child is PEWSing 6, and the doctor is not listening to me. So I will, these are not for me to read out. This I just picked up from my guideline, which I'll show you at the end. It's a lengthy document. So when a guideline is made, it just becomes an official trust or official hospital document. And this I just picked up. So you can see that even in a temperature, which Rida said is very easy to do, you know, anybody can do it. But even in a temperature, heart rate, and a respiratory rate, blood pressure, cap refill, they have to follow these ones. So they've made it this sort of idiot proof. So they have said, okay, if a nurse comes in on a shift and she is new, she's a bit, you know, she's a bit hesitant to ask, you know, how to do a capillary refill time. The PEWS chart is in front of us. She's like, oh, this is cap refill time. How do I do that? So she will go to this document, and it will tell us, it will tell her how to do a capillary refill time. And again, very interesting. So can you see this doctor, nurses, family concern? This is also score. This also scores. So I'll go back to my PEWS chart. Where is my concern? So there it is. Oh, look at this. So let's say, for example, look at this 13 to 18-year-old chart. So in all of these charts, doctor, family concern, can you see that? So if a parent is concerned about a child, it just automatically scores. So it is not a perfect tool. Like, let's say, for example, a 5-day-old or a 7-day-old first-time parent has come in, and he's just hungry, and there is no milk. Let's say, for example, I'm just giving you a scenario. And that child is crying. Let me go to his, for example, he's scoring on this 0 to 11-month chart. He's crying his head off. What will his respiratory rate be? Probably 60. So he will not score over here. The nurse may think he's sucking into his chest, so he may score 1 over here. His heart rate will definitely be 200. Yeah. So he will score a 2 over here. And the mother, who is a first-time mom, she will be concerned a lot. Yeah, she will be crying. The baby will be crying. He will score 3, and he may be a bit cold as well. Yeah, so he may score a 4 over here. And just because he's crying his head off, his cap refill may be a bit prolonged, 5. Now you will go and assess that child, take a history, assess that child, and you will say, oh, this child is just a hungry child. But based on your experience, you can decide that. But a score of 5 doesn't automatically mean that you have to call the pediatric retrieval service. Yeah. So you have to take your clinical judgment into account as well. So now, as I said, this I've just touched upon, that there is an escalation policy. So let's say, for example, if somebody is scoring 0, 3, 4, how do they escalate? And then how do they communicate with a doctor? So something called, so it's just something for you to know. And over here in every UK hospital that you work in, I'm pretty sure this is in adults as well. Correct me if I'm wrong, but I think it is in adults. This thing called S-bar, situation, background, assessment, recommendation. So they've made it so idiot proof that, let's say, for example, a nurse who is coming in on a shift, a junior nurse, she doesn't even know how to talk to a doctor. Yeah, that when she picks up the phone and bleeps someone or calls a doctor, so this is what she has to say. I am whatever. Yeah, this is my name. I'm a nurse on ward this. I'm calling about child this. I'm calling because I'm concerned that PEWS is 5. Yeah. She will tell the background, even if the doctor doesn't know about the child. He's a locum doctor. He's just coming. He doesn't know any of the other patients. She will tell him about the assessment which she has done. And she will recommend, well, all the nurses over here will recommend, I want you to come here and assess the child. They will just make it very easy for themselves. And then they will document in the notes that this is what I recommended to the doctor. And this is what I was telling you. This is similar to that previous chart. If a child scores 2, it's this, 3, this, 4, this, 5, this. Okay. How much time do I have? I'll go very quickly. So this is just a very basic BLS algorithm. So just for you to know that, let's say, for example, if a nurse calls you and you go in and see the child, what do you do? Yes, you have seen a few PEWS of 4, but you make sure that you follow the BLS algorithm. Sorry, you follow the BLS algorithm. And you make sure you cover airway, breathing, circulation, disability, exposure. This is in this order. I know sometimes adult resuscitation practices have now moved to C first. Correct me if I'm wrong. But because in some instances, like in trauma, or if there's acute blood loss, which you have seen, you have to cover circulation first. But still in pediatrics, we still follow the same A, B, C, D. And this is quite logical, because if you have not covered airway and you start to put in a cannula and giving fluid to someone and their airway is blocked, they will die due to hypoxia, not due to you not cannulating the patient. So it's always in this order. And then a very short, AMPL is a mnemonic for allergy, medication, past medical history, last meal. And what is E? Exposure, I think. No, E. Yeah, I think so. So this is what you basically follow in your history. A very quick history. Somebody who is unwell, like let's say, for example, you have just gone in, seen a child, and the parent is there or the nurse is there, and you have no idea about the child. That's when you can take a very quick history after covering A, B, C, D, E. So don't start taking a history when a child is dying on you. Yeah. Again, this is just to give you a flavor that this is, again, in all UK hospitals, they will again keep on singing this thing called wet flag, wet flag, wet flag. Just this is a mnemonic which stands for weight, energy, tube, fluid, lorazepam, adrenaline, glucose, and this is what it stands for basically. And the good thing, I think, compared, so there's some good things in Pakistan, there's some good things in UK, but over here the good thing which I found, that you don't have to memorize anything. You don't have to memorize any drug dosages, any tube formulas, any fluid formula you should know. It's very straightforward, 20 mils per kilo. But the rest, you know, like a weight of a child, if a child comes into the emergency department, or you have gone in to see a child, because somebody can tell you the weight, like this is a 2-year-old. So you will say, okay, 2-year-old, what fluid do I give him? So 2 plus 4, 8, 8 times 2, 16. Yeah, so 2-year-old should be 16 kilos. And then you can very easily give him 16 times 20, 320 mils of fluid. Yeah. And it will tell you 0.9% saline, because that's what we use in kids. Now, this is just to let you know that PEWS, yes, PEWS is a chart, and people acutely unwell children will score on PEWS, but a low PEWS does not rule out a significant medical deterioration. Yes, and some of my oncology colleagues will agree to that, even adult oncology colleagues. Same goes for pediatric ones. That let's say, for example, if a child is on chemotherapy and they're a high dose chemo, their CRPs may not respond. They may not show any acute, and they will suddenly crash. Yeah. But if a nurse comes in and tells you, or if a parent comes in and tells you that this child is scoring just 1, but there's something not quite right about this patient, and I'm just not very happy. So I was telling when we were doing the practice run yesterday that over here in the UK, you have to keep everyone happy. Nurse has to be happy, parent has to be happy. But if they say, I'm not happy about this child, but if you hear this, you have to go and see the child. Or if they say something is not quite right, I just don't have a very good feeling about this child. Even if they're scoring 0, you still have to go and see that child immediately. Leave everything else and go and attend to that patient. Now, I'm not going to go into a lot of detail with this slide. I wanted this to be an interactive sort of question and answer where I ask the question and my Saidu colleagues, they answer. But I want to know whether you guys have any sort of a structured handover system in your ward or in your department or in your hospital. Does such a thing exist? So it's a question, broad question.
We do have register. Yeah, Dr. Sheriar, we have a structured handover system over here and different departments. The structured handover exists among the doctors,
Yes.
among the nursing staff, and among the security guards in all the class 4 as well.
Okay. So,
and such handovers help the system a lot, which helps in keeping the continuity of care of the patient as well.
Awesome, awesome. It didn't exist in Hayatabad Medical Complex when I was there, and I don't think it exists in Sherpao as well. It doesn't. Sorry, Khyber Teaching Hospital. It doesn't exist there. Well, in pediatrics, it didn't exist. So, do you guys do like a paper handover or just a verbal handover? So, what do you do? It's not basically. I'm not undermining anyone. I just want to know about how far our system has moved.
As I'm from cardiology, in our department, we have developed the different registers on which the doctors do their handovers on the proper written statements. They do sign the morning, evening, and night shifts, and same exists among the nursing staff as well.
Okay.
And we have different colleagues.
In pediatrics, we have maintained a register in which the doctor, the serious patients, the notes are written and they are handed over to the.
But not every single patient, yeah.
No, because we have a lot of patients, so it's not practically possible. Because we have,
how many patients roughly on a pediatric ward? Just roughly, how many beds?
In a single ward, we have 80 to 100.
How many? 80 to 100.
Yes.
And how many doctors, let's say, for example, at night, how many doctors will be available on the ward?
Two house officers and 2 TMOs.
Yeah, so people will be PEWSing left, right, and center, I think, on a night shift. I don't know how you guys will attend. So 80 patients on a ward, and then emergency patients also coming in. So yes, you may say that, it's very easy for you to say, or for Reda to say that you have to attend to a deteriorating patient when you just have 20 patients on the ward or 25 patients on the ward. But how can you respond to 80 patients not all of them will be deteriorating, but probably 4 or 5 will be PEWSing, or they will be very high. So how can 2 doctors who will be working in a team, one doctor will be taking emergency patients, because I know in HMC and KTH, emergency doctor didn't exist. All pediatrics would come to the ward. I remember that inflow. So how
We
can...
have a separate, here at Saidu, we have separate emergency.
Very good.
24/7 separate department. So
even pediatrics are seen. Even pediatrics are seen in emergency.
Pediatrics we have.
Okay. Okay. No. I think you guys have moved forward. So you're better than Peshawar at least. But I'm not saying who is better, who is wrong. I think it's just the patient load. The workload in Peshawar is probably 2 times that of Saidu. So that's why, they will say, how do you expect us to, respond? But I think that shouldn't be the attitude. The attitude should be that, okay, something like PEWS exists. Let me just bring it to my department. Let me just bring a structured handover system to my department. Change is very, very difficult, isn't it? So change, even in this country, PEWS is still not a recognized tool. Not every hospital has it, but every hospital has a different PEWS based on what they're comfortable with. So, and it's not recognized. Nobody can take me to court and say that, oh, this child was PEWSing 4 and 5 and you didn't do anything about it. I will say, well, it was my clinical judgment. I didn't think this child needed escalation. So I know it can be very difficult to practice a structured handover fully in a very busy pediatric ward, like 80 to 100 patients in one ward. So this is what we used, in one of the hospitals, where it's sort of a computer based. So we would, over here, I think in every UK hospital, what happens is that you will have patient, you will have the situation of that patient, what they are coming in with. There will be a background which all the junior doctors will update. Sorry guys, my kids are shouting. So they will write the background, and then they will write their assessment or their blood tests, and then they will write either recommendation or jobs, what they need to do. And this will be printed out twice in a day, and the junior doctors will update it, in the morning and for the night shift. So before the night shift and before the morning team comes over. So they will update it. And I think this is standard across the whole country. Everyone should be doing it. I hope everyone is doing it in UK. And it's a written as well as a verbal handover. So you take a break for half an hour to 1 hour, you sit down in a room, and you just basically read through and go through and discuss all the patients. I understand. I don't know how you will be able to discuss 80 patients. So I don't know. I don't have an answer to that. So conclusion. Well, early identification of children at risk is important. So, and PEWS can assist you. PEWS can assist you in early recognition. So it's a very sort of easy tool to use for the nurses. They just have to, say this is the PEWS and speak to the doctor. Now, this is quite interesting that a high PEWS should be taken seriously. But as I said, a low score is poor at ruling out requirements for an admission. So it's got a high specificity, but a very low sensitivity. So it's very specific at picking up unwell children. But a low test does not rule out a significant medical condition. And in the end, always trust your clinical judgment. And listening to your colleagues and parents is of utmost importance. Any questions? Thanks a lot.
Thank you, sir.
Thank you. Yeah, very nice talk and very comprehensive as well. As you said, these principles can be applied to the adult clinical setup as well. And it will be challenging, and our setups back will be working due to workload, due to the resources available, and also the way it works. But at least if, as long as we know that there is a system in place, and this can be sort of a quality improvement project for the trainees, and this can be like they can do audits through it. And as Shariar said, we are more than happy to share these slides and these protocols that you can modify it for your local setup. And hopefully that should help, that will benefit us, that will benefit our patients in the long run. And this is the main theme of organizing these sessions, basically to share our ideas, our experiences, and learn from it, and just to help get the system much better for the future. And yes, I myself am surprised as well. We have progressed quite a lot. I myself, my house job was in late reading hospital. So yeah, there wasn't any handover system. There wasn't any sort of PEWS or PEWS system over there. So if we are doing some sort of handover, we can refine it, looking into these approaches, and we can refine our observation system as well. And that should help, that definitely will help. Thanks a lot. Any comments or any suggestions?
Dr. Nizam, I would suggest that the session, if it is possible, could be make it in midweek, because on Saturday our attendance is very thin.
Right. Okay. Right. I'm afraid the issue with that is the timing. Basically, the timing. There's now 4 hours difference, and soon it will be 5 hours. So
for us, the timing is okay, but the day is not. The day is not okay.
Yeah. I mean, we start working here normally 8 or 9 o'clock, and preparing for work, and going to the hospital. So we'll have a chat about that. Definitely, we will chat about it and see what we can do. And if we can do it over the weekdays, especially if someone is off, for example, on their annual leave, and if they are happy. If someone is on annual leave over here, usually we have a lot of things to work on as well. So I can't promise, but we will certainly chat about it and see if there's any possibility we can do it on weekdays. Okay. Yes, definitely. If there is more audience, it will certainly help. We will look into that. But the reason we choose Saturday is most of people are off. And I mean, by this time, we should have seen almost half of our patients. We are off, so that's why we chose Saturday in the first instance. But there will be in the future, we'll be doing talks or sessions on these there are quite few suggestions from our colleague we got on our own WhatsApp group. Some of them are like that, but more than happy to get the feedback from your trainees yourself, what we need to discuss, and we will be happy to prepare that for the future talks.
Thank you, Dr. Nizam, and Dr. Shariar for giving a very comprehensive talk on the PEWS, and then Dr. Rida Jamil, who had a very practical and brief account of the news, and which will definitely help the trainees and the junior consultants who are here as well. I'm also thankful to Dr. Zeba Salim for facilitating all these process, and no doubt Dr. Nizam for conceiving this idea. Inshallah, we will remain in touch with you. We will have feedback from our trainees, and we will let you know in the future, in the near future as well.
Inshallah. Any other comments from my panel, colleague Shariar or Zavia Salim, before we end this session? We are all good. So thanks a lot. Thanks again, Prof. Ahmed Iqbal and Assistant Professor Abdul Hadi. And thanks to all the attendees. We'll see you soon in the future.
Thank you very much, everyone. Thank you very much. Allah Hafiz.
Allah Hafiz.